thought he was thinking of Jackie. I said, you think of Norman Stan? I said, tell me.
He's done one of our shirts actually with the little dog. That first shirt.
You're all set, Linda.
Maybe that was before your time.
Okay, I think we're going to start. So it's 11:45. That's close enough. So this is a talk about heart rhythm, because that's sort of an important concept, especially for all of us. And some of this you've seen before. And EKGs, you know, have been around for a long, long time. And I guess back in the 1800s, some guy realized if he stuck his foot in a bucket of water, he could measure the voltage in his body, which is what an EKG is about, looking at the voltage traveling through your body, which it's everywhere. So you can, EKG is looking at the voltage in your heart. You do an EEG, that's looking at the voltage in your brain. You do an EMG, you're looking at the voltage in your muscles. It's all, this voltage is just everywhere. And just tracking it is super interesting. And this is a picture. How do I get rid of this stuff on the top here? Oops. This is a picture from Dr. Capagoda, which I am blessed to still have. So, you know, your heart, that's a picture of your heart, and there's lots of things that can go wrong with it. You know, the muscle can be damaged, the valves can be congenitally deformed, they can develop abnormalities with age and extra pressures. Your arteries, the things that cover the heart, can be diseased. The actual sac, pericardium, can have an issue, can be inflamed. That's a disease of the covering. And today we're talking about conduction. So that's the electrical system of your heart. And there's myriad things that can go wrong with your heart conduction. And it's really the fundamental, the thing that keeps you beating is the fact that you do have a conduction system. But any of these issues, basically, you're going to compromise your function if there's something that's kind of affected. But today we're just talking about conduction. And so, you know, this is a little schematic of the heart. And you've heard these words before, systole and diastole. And systole is when the heart is squeezing, when it's contracting. Diastole is when it relaxes, when it opens up. So that's what your heart does, is it squeezes and opens. Squeeze, contracts, opens. And so when it squeezes, obviously there's a lot of pressure, which is what this pressure wave is about. And then when it relaxes, the pressure goes down. So every time your heart squeezes, the pressure is going to bump up to push the blood around in the heart. So you've probably might have seen these things on the hospital screens if you're hooked up to some of those fancy machines. And the EKG is the one that's actually looking at the voltage that's traveling through the heart. And each of these little electrical blips sort of corresponds to what's going on with the squeezing of the heart. Okay, we're going to talk about that. And so this is another schematic of the heart, and you might remember that, you know, it's got top chambers, these atrium, it's got lower chambers, these ventricles. So this is it's sliced open. And this is a picture or a cartoon, Dr. Lopez calls them, of the conduction system. And it's not like you have actual wires inside your heart that are this conduction system. They're just specialized cells that are part of the heart muscle themselves that are called pacemaker cells. And these cells, what they do is they just basically transfer the voltage from one cell to the next on down the whole chain. And so the super important part about your conduction system is this thing here called your SA node, your sinoatrial node, which is this just collection of little nervous pacemaker cells right here at the top of this left atrium. And so that SA node is your what's called intrinsic pacemaker. This is a thing that throughout your life is just emitting signals and sending out little blips of electricity, right? And so the voltage that's being generated from the SA node, it's just doing its thing, blipping away, and that voltage travels through the atrium down these specialized tracks through another little node called the AV node, which is because it's the atrium and the ventricle. So the AV node is another specialized collection of cells that transfers the voltage down the chain. And from this AV node, then it goes down into the ventricles, and you see how it's split. So it goes into the left side, into the right, the left side and the right side. So these splits are called bundled branches. Okay, so that's a typical way that the voltage travels. It starts at the SA node, travels through the atrium, and then down into the two bundles. And it's the voltage traveling along through the muscle that makes the muscle actually contract. So your heart's job is to pump blood. Your heart pumps blood when it squeezes, and the blood goes out into the aorta here, and it knows to squeeze because it was triggered by the voltage that's traveling through it down this conduction system. But this is our conduction system. This is the wiring in your heart. As I said, it's not the wires, but it's just specialized tissues where the voltage travels. And then that voltage, if you look at this peripheral EKG, you can see that each of these little blips kind of represents where that voltage is traveling. So the SA node here, when the voltage is there, that's reflected in this blip on your EKG called a P wave. So this P wave is an important thing in your electrocardiogram. So your P wave represents the fact that your SA node did its job, okay? So you have a P wave, the voltage started, and then it travels down through the atrium, and then it goes to these two bundles and makes the heart squeeze. And so when the heart is, voltage coming down through these bundles is squeezing the heart, making the ventricles contract, you get this nice big tall blip here, which is called a QRS complex. So this QRS complex, this collection of actually three different waves, a down, an up, and a down, that represents the ventricle squeezing, okay? And then this T wave is a thing called repolarization. That's just things kind of getting back to normal. But a normal heartbeat basically is a P wave followed by a nice big tall QRS, meaning that the heart squeezed and pumped out the blood, okay? So you hear your doctors all the time talking about your P waves and your QRS, et cetera. And that's what these waves represent, what's going on with the heart with respect to how it's contracting, okay? And this is really the same thing. I'm not sure why that's two pictures. Okay, so one heartbeat basically is this collection of a P, a QRS, and this T wave. And as we said, this P wave represents the atrium doing its job, and this QRS represents the ventricle firing or contracting. And when an EKG is run, there are standard things. It's supposed to be running with the paper at 25 millimeters moving per second, and an amplitude where 1 millivolt basically is 10 millimeters. And so that means stuff to the doctors because they can look at that and make determinations about the timing between the P wave and the QRS, and the timing between the whole QRS. And so if it takes a long time, if the QRS is super wide, meaning it takes a long time for that voltage to travel, that may or may not be meaningful. More meaningful is if there's a P wave and then a big lag before this QRS. Those are the things that doctors are looking for. Are there timing things that go on with respect to when these waves are happening? Because that timing is reflecting what's going on with how the heart is beating. And that's just, it's all standardized. So obviously you have to know that an EKG was run at the right paper speed and with the right voltage settings, because you could have this ginormous QRS complex, but if the voltage is turned up on the display, then it's misleading. So you do need to know that it was run at standardized settings to make any interpretations about it. Some other things with respect to that 25 millimeters per second, which this is meaningless to you guys for the most part, but these lines mean something. So if you start at this line and you count over a centimeter away, so 10 millimeters, that represents with 25 millimeters per second a certain amount of time. And so if you have a heartbeat here and you have a heartbeat here, those are really close together, and that means the heart rate actually is going about 150 beats per minute. And if you have a heartbeat here and you don't have one to control over here, that's 4 boxes, then it's 75. And that's just a way some people that are truly smart and can read the paper can look at it and say, okay, well, that's a heart rate of 60 or 70 or whatever. For the most part, we just look at the numbers. If the machine counted it for us, we don't bother. or we have little special rulers that help you count the distance, but it really all is just arithmetic. And there's a certain amount of space between here and here, and you can determine how fast the heart is going because you know that distance if it was running at 25 millimeters per second. So if you look at these different tracings, they're all kind of different. So there may be different angles, different hearts, etc. But I think the only point I'm trying to make here is that obviously this one, where there's a lot of distance between each of these QRSs, that's a lot slower than this one down here in the middle where they're much closer together, right? So this is a faster heart rate than this. And this is sort of in between those. And you could count the boxes. So here's one's right on the line. So that was 150, 75 would be here. So this is about 90. This tracing here is about 90 beats per minute. And I've forgotten how to do all of that now. But anyway, that's just something to be aware of. That, and if you also look at these tracings, this distance here, here to here to here to here to here is pretty even. So this is at least rhythmic. Okay, it's in rhythm, and there is indeed a P wave, P, 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 P for every QRS. So this is a kind of a nice normal rhythm because there's a P for every QRS, and it's rhythmic. Every beats are consistently. This tracing down here is not that way, right? The distance between each blip is a little different, and the P waves are harder to discern. We'll talk more about that. So we mentioned that your sinus node is the thing that's emitting signals. And so a normal heart rhythm is basically what's called sinus rhythm. So normal sinus rhythm is what is normal. Okay, so if you're in sinus rhythm, you're in a normal heart rhythm. And if you're in sinus rhythm, that means that you have a P wave for every QRS. Okay, so this is an example of normal sinus rhythm. And then these are also examples of normal sinus rhythm, but this particular tracing is slow. This particular tracing is fast. So if your heart rate is slow, if it's under 60 beats per minute, then it's called bradycardia. That just means it's slow. Okay, so sinus bradycardia is a normal rhythm, it's just slow. Sinus tachycardia is a normal heart rhythm, it's just fast, it's over 100. So when you're exercising and getting your heart rate up, if you're over 100, you're in sinus tach. That's a normal scenario, okay? It's okay to be in sinus tach because that just means your heart rate's going over 100. And it's okay to be slow, to be under 60, especially if you're just sitting there. If it's super slow, if it's like 40, that's a little more problematic and needs to be addressed. But being slow is not bad, being fast is not bad, as long as it's interpreted with what's going on with what you're doing. If you're sitting in a hot tub, if you're climbing a mountain, etc. Those all kind of matter. So this is just another example of that conduction system, the sinus node under the AV node into the two bundles, and that's how you get normal sinus rhythm. But what's important to note, and this is where the different rhythm issues come in, is that yes, you have this normal conduction system, and if the voltage is traveling as it should down through the whole system and you have normal sinus rhythm, everything's cool. But I think the heart's kind of an interesting organ is because there are many parts of it that can basically generate electricity and send out a blip just because it wants to, okay? So you could have a part of the atrium sending out a signal that's not part of the normal conduction pathway. And if it does that, if it fires over here and it interferes with this normal conduction from the sinus node to the AV node, you might have an early or a late heartbeat, okay? So that's not uncommon. It happens all the time. So here's an example of, more or less normal complexes. So here's PQRST, PQRST. This blip here, though, there's no P wave. And here's a normal one, normal, normal, early, normal, normal. So these early beats here basically are because the atrium sort of fired on its own without following the normal conduction pathway, which is why there's no normal P wave. So it's called a premature beat because it's early. See how it came quicker than it should have. And since it came early, then it interfered with the next beat that's going to happen. So there's a little bit of a space here. And so if we're feeling your pulse, Mary's really, really good at this. And she feels your pulse and she's hearing dot, 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 then there's something we're kind of aware of that maybe you're not rhythmic, you're not totally rhythmic. And why are you not rhythmic is the part where you have to look at it and figure it out. And PACs are certainly pretty common, no big deal, because yeah, what little this beat came early, but you still beat and you're still beating and everything's all cool. And those junctional versus atrium, just it depends on where the extra voltage kind of came in, and it doesn't matter so much. They're really kind of the same thing with respect to how you're feeling or what you're feeling. And they're not super serious. Some people have a lot of PACs, some people don't have hardly any, but for the most part, they're considered benign and people don't ever really worry about them. Going back to that atrium, so the voltage is supposed to go from the SA node to the AD node, but sometimes the atrium is basically kind of wigging out and it has lots of activity. And this is what we see a lot of in our program here. So if there's a lot of activity in the atrium and it's firing all the time, and only every once in a while a beat comes through, then this rhythm is what, Jane? Atrial fib. Okay, so when you're in atrial fib, that means that your P waves are kind of messed up. You have too many of them, basically. And since you have a lot of extra, like this sawtooth putter is the best example, there's just tons of P waves because the atrium is just basically, you know, spazzing out, doing all kinds of stuff. And every once in a while, a beat gets down to the AD node and it makes the heart contract as normal. Okay, so that in and of itself is kind of okay, because the bottom line is the heart's still beating. Okay, if you're in AFib, yes, your atrium is kind of wigging out, but enough signals are getting into the ventricular pathway so that you have sort of normal contractions of your ventricles and you're pumping blood to your heart and everything's cool. The thing to be mindful of in atrial fib is that the atrium can go really fast. And so sometimes if people are in atrial fib, their heart rates are super fast. They're very tachycardic. They're like 130, 140. And that's kind of wearing. You know, you don't feel so good if your heart rate is 140 and you're just sitting there. So that's one reason why atrial fib is of concern, is because it can be a rate that's out of control. And the other issue with atrial fib is the fact that the ventricle is not, the atrium is not squeezing fully. And so basically there's a tendency for clots to kind of form. And so your likelihood of throwing a clot is higher if you're in atrial fib, which is why when people go into atrial fib, they almost right away get put on a blood thinner to reduce their clot risk, because the huge risk from all of that, a fast heart rate with clots forming, is having a stroke. And so being an atrial fib is not a crisis. It's not a crisis, but it is something that basically should be addressed because it's setting you up for potential risk for other things. It has a lot to do with age. And the thing so the risk factors for AFib are getting older and having other issues like high blood pressure, being diabetic, having sleep apnea, having heart kind of diseases, predisposition. So all of these kind of fit into make people more at risk for AFib. And I think a huge one is the age. And here's just another example of AFib. So it's not rhythmic because, again, the beats are not getting through in a consistent pattern, but enough of them are getting through that so you're beating. So this rate's not super fast, probably in the 80s, but it is not regular, so it's AFib. And this has way too much information on it, but it's just, here's a picture of all these risk factors for AFib and an acknowledgement that it's kind of a potential future health issue for the world, because our population is aging and more people are getting older. There's more old people around. So the expectation that while there's 2.7 million people with AFib now, by 2030, that's expected to kind of double and even be a lot higher by 2050. And I'm sure these are just projection based on aging populations. Those are, CVD is cardiovascular disease.
Oh.
and CKD would be kidney disease. Chronic kidney disease.
Psychosocial.
Psychosocial, it just is your
Depression.
economic, your well-being, your makeup. So I think the things that are kind of interesting about what puts you at risk factors, and it sits in with our program super well, is it's really all basically kind of lifestyle things, that the habits and the behaviors that you have that contribute to your health are going to lower your risk for developing AFib. And if you don't take care of business and you let your blood pressure continue to be out of control and your diabetes and you continue to smoke and you don't basically take care of yourselves, then you're more at risk for having AFib as you get older. And echo just looking at how your heart is beating, how it's functioning. Yours is going to be normal.
Still no cure for aging.
There's no cure for aging.
Can a major life event cause it all of a sudden?
Stress, probably.
I'm thinking about that teacher whose wife was went and shot and the next day had a
Yeah.
heart attack. And they say he died of a broken heart, but I mean, I assume that was that was a big.
Right. It was a stress related event, sure.
Yeah.
But whether he was an AFib, we don't know that.
Oh,
Okay.
that's true.
So right now, 3.3 million in the US have AFib. They expect it to double by 2035. And obviously the issue is that if you're in AFib, your risk for stroke is much huger. And so that's what they're trying to prevent, because that's where the healthcare cost comes in, is keeping you out of the hospital and keeping you from having a stroke. And this is just a little schematic of the treatment for AFib, which Dr. Buka Putnam has done several talks on AFib for us, and some of them are posted on our webpage actually. But we mentioned how the bigger issue is your rate might be out of control. So that's commonly something that you're given medicines to control your rate, whether it's a beta blocker or a calcium channel blocker. And you're put on blood thinners to reduce your clotting issue for your stroke rate. And you might be put on other more heavy duty arrhythmic drugs if your rate's not well controlled, et cetera. And there are other things they do sometimes. You know, they do cardioversions where they shock you and try to get you out of atrial fib.
I don't understand.
Exactly what it says. They put the paddles on you and they shock you. And I think that's, these other more invasive issues are,
I'm sorry, is that supposed to bring it back to normal?
yes,
Resets it.
supposed to reset it. Yeah. And sometimes they do these ablation things where they go in and zap a little bit of the atrium, where it's they've determined from a study that that's the tissue that's doing all the bad stuff. So if we just blast that and make it go away, then you might cure the AFib. And that's happening. And those more invasive kind of procedures or higher risk things are typically done in people when they're younger. You know, when you're 85 and 90 in AFib, you might opt to have those procedures, but more than likely they're just going to want to medicate you and make sure that your rate is controlled and that your stroke risk is lower.
Yeah, my younger brother just had them. They just filled out his.
Yeah, he had an ablation.
Center.
Yeah,
Frozen, basically.
yeah,
Now he's completely dependent.
right.
I didn't know they could do that either.
Yes. Anyway, so those are, just an awareness of that's where you're headed. And then, so going back to the part that any part of your heart can basically elicit a signal. When you do stuff in the atrium, it's generally considered kind of benign, because if the atrium is spazzing out and it's eliciting signals, whether it's an atrial fib or just having some premature atrial beats, it's really all okay as long as things get through and you still have basically normal conduction in the bottom chambers and the pumping chambers of your heart. But obviously there's parts of your heart muscle on the bottom chambers that can do the same thing. They can generate a signal and send out a blip of exercise. And if over here, some electricity came in and put some voltage into the heart that threw out when the pathway, the beat was coming down and this extra signal came in, it can kind of mess that up, right? It's going to interfere with a pumping beat if you get some extra electrical activity outside of the normal pathway and it's in the ventricle. So when that happens, you know, here's a normal complex, normal, normal. This beat is early and it's really weird looking. So this is a premature beat that came from outside the normal conduction pathway. So it's a premature ventricular contraction, a PVC. And in this example, 1, 2, 3, 4, 1, 2, 3, 4, it's every fourth beat. So that's why it's called quadrigeminy. So that can be a case where that little piece of tissue that's irritated is sending out signals that can do it kind of rhythmically, and it's over and over, and it's doing it, you know, in a systematic timing fashion so that it is interfering with every fourth heartbeat. And again, if you were feeling your pulse, it would be dut, 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 dut. It'd be slightly off. And then if you thought about that, so this extra heartbeat here, this premature ventricular beat, sometimes, you know, this tissue can be so irritated that it does that repeatedly. So down here is an example where you're doing 2 of those in a row. So dot, dot, dot. So these beats here are these premature ventricular beats, and they're problematic because they're interfering with the normal beats that's going on. So basically, if you beat here and you have this nice long pause and your ventricles doing this electrical activity, you're not pumping blood to your heart for this amount of time. So again, and depending on the timing, that may or may not be an issue as long as you're still getting enough beats in there so that you're pumping blood. So, you know, doing a PVC once in a while is okay. Doing a lot of PVCs is more problematic. Doing these PVCs in couplets is slightly more problematic because it's basically just more interference with normal pumping function. And if you're doing 2 beats in a row, your likelihood of doing 3 beats in a row is greater. And if you have 3 of these extra beats in a row, that's called a run of what's called V-tach, or ventricular tachycardia. So sinus tach is a normal heartbeat that's just fast. Ventricular tach is, again, a fast heart rate, but it's not normal. And so if you're in a V-tach, that's problematic because that means basically you're not pumping blood normally to your body, to your brain. And again, so that's not a good thing, especially if you're driving your car or whatever. So your doctors are concerned if you're running around having a lot of V-tach. Okay, they want to do things with you. They want to maybe do some surgical thing, intervention. They maybe want to put you on medicine to control that, whatever. They want to address that. And they might address it by, and which is what Dr. Buck-Cutton will talk about, giving you a device, an internal defibrillator that if you're in V-tach, the machine will actually shock you out of it. So that's what V-tach is. And again, it's all a matter of degradation. And so having a lot of PVCs sets you up to having a lot of complex ventricular ectopy, and having a lot of complex stuff basically makes you more at risk for doing nothing but this ectopic stuff. So if you're in continuous V-tach, well, that's a bad thing. That's a issue where maybe you're walking around, but you're not going to be walking around for very long. And if you're in V-tach, they want to do something with you, which is where they want to shock you out of it. They want to defibrillate you. And if you're in V-tach, again, you might be pumping a little bit, but the next step from V-tach is what's called V-fib, where again, it's just the heart doing this spastic electrical continuous activity, but there's no heart pumping going on. So V-fib obviously is a life-threatening situation where you need an acute, immediate situation to make it go away. Because the next thing after V-fib is what? Flatline, exactly. You're not beating it all. So there's just some jargon, okay? So we talk about PACs, and Mary and I are old, so we have a lot of the old jargon. So we say PACs because that's what how we learned it. And PVCs, we say that a lot. But there's other words that mean the same thing. So a PAC is a extra heartbeat, an ectopic beat that came above the ventricle, so it's called supraventricular beat. So an SVE is a supraventricular ectopic beat. That's the same thing as a PAC. And Mary and I call them PACs. Other people might call them SVEs. Same thing. And the same thing for PVCs versus ventricular ectopic beats. So it's jargon. But the ectopy, that word makes sense because if you have an ectopic beat, that means you have a beat that came from something outside the normal conduction pathway. So you can have an ectopic beat in the atrium, in the supraventricular space. You could have an ectopic beat coming from the ventricle, and those are the ones that are more serious. But there's lots of times when you have these skipped heartbeats for all kinds of reasons. Sometimes people are more prone to them when they work out. Pregnancy might interfere, caffeine. Some people might have more ectopy if they are sensitive to caffeine or other chemical things like alcohol and smoking. And obviously, it doesn't hurt to be aware of that. If you know that drinking a lot of caffeine is going to make you have PVCs, a logical approach would be to not drink so much caffeine, right? But those are individual personal things. So again, we all have these ectopic beats probably several times a day, and it's the quantity and the complexity that makes them more serious than other times. So if you have underlying heart disease and you're getting chest pain when you have PVCs or out of breath, then you need to be mindful of that. And there might be situations where the medicines that you're taking are contributing to it or not. It's not on this slide, but something that sometimes does interfere that kind of makes sense is if you're having dental issues, you're having stress related to stuff going on in your mouth, that kind of sets you up. And sometimes people do have a lot of extra ectopy just because their teeth are kind of out of control. And if they go to the dentist and get their teeth taken care of, their ectopy might be better. But again, it's all individualized and you have to just be mindful of what you personally are doing. I wanted to mention one other conduction thing, which you may or may not have heard of, and that's this thing called bundle branch blocks. Those are relatively common, and it's not that the wires are broken. It just means that the conduction is slow going on one side versus the other. So these things down here are those bundle branches. So you have one on the right, you have one on the left. And it could be a situation where the conduction is slower on one side than the other for whatever reason. Maybe you had a heart attack and part of this heart muscle is slow, so the conduction is slower on that side. And if that's the case, oh, I guess I showed you that, then your QRS is going to be affected. So if you have a wide QRS, because the conduction is going slower on the left side than the right, you have what's called a left bundle. And if it's wider, if you're slowed on the right side, you notice it sort of has this bunny ear thing. There's actually two QRSs because that's indeed what's going on. The conduction is going down those two bundles, sort of not in synchrony. It's a little bit dysynchronous, so that the right side is going a little bit slower or faster than the slower in this case than the right. So that's why it looks like it's biphasic, like there's two QRSs. It's just wider because the conduction is going slower down one side than the other. And again, it's not a problematic thing as long as it still happened and the beats still happen. So it's still a pumping beat and blood is getting pumped around. It's just going slower on one side than the other. So lots of people run around with bundle branch blocks all the time, and it's just their underlying heart rhythm. It's useful to know that you do that, though, just because you want to know if it's something new. If you didn't have it before and now you have it, what happened? But if you've always had it, it's just the way it is. It's just how your voltage travels. There's other things that doctors learn. We're not going to spend a lot of time on this, about your ST segments, and those relate to your perfusion and how much heart, your ischemic picture, how much oxygen and blood is getting to your arteries itself. And so when you do a rated exercise test and they're hooked up to an EKG machine, this is what they're looking for, what's going on with your ST segments, because that can be diagnostically important to tell them how the blood flow picture is going in your heart. An EKG is a common diagnostic tool if you go into the hospital with chest pain to make sure that you're not indeed having a heart attack, because when you're having a heart attack and your heart muscle is doing different things like trying to die, then obviously the voltage is going to be traveling differently through different parts. And so doctors can look at your EKG, can look at this, there's this hugely bizarre elevation in these segments here. So this is an MI that's happening as they speak. So if you go into the ER with chest pain and one of the first things they're going to do is do an EKG on you, and that they find you doing this, you're probably going to be in the cath lab in the next 2 or 3 minutes. Okay. So it just, the EKG is kind of a fun, useful thing where you can learn a lot. And I didn't want to spend a lot of time talking about heart attacks. Okay, some other things that doctors learn from EKGs, which will be relevant when Dr. B comes and talks in a couple of weeks, is, sometimes that this conduction is affected, is kind of messed up. And if you have a thing called heart block, meaning that there's something going on and the voltage is not traveling super well, and basically the beats aren't getting through, and so we're going to call that heart block, it's kind of a good term, then obviously if this is what's going on in your system, so there's a P wave, but not really a QRS, people like this end up getting extrinsic pacemakers, right? They get a device put in that's going to put real wires into their heart that's going to send signals that it's going to make the ventricles contract. And those are super sophisticated anymore. And some of them have 2 wires and some of them have 3 wires, and they have a wire in the atrium as well as a ventricle. And they might have wires to each ventricle, et cetera. It's all dependent on your underlying issues for why you needed to have this outside electrical stuff going on. So here's this addition. So here's the normal beat, but then here's some P waves with no QRSs. So that's not a good thing, obviously, right? All the beats aren't getting through. That's heart block. I had so much about that. And I wanted to share this. I don't know if you remember this, John. So when we very first started, we had a wonderful EMT who helped us get us going. And this comes from him. This is his analogy, which I think is super, it's fun and it's useful. So this analogy has to do with this ectopic stuff. And so in his analogy, he said the sinus node is like a teacher in control over a classroom. And so as long as everything is firing normally, as long as the beats are coming through as normal, it's it's a calm situation, and there's control going on, and everything is great, and learning is happening. And then you could have some problems in your classroom. You could have 1 or 2 kids that are not participating as well as they could. So those problem kids are representing the extra electrical activity that's outside the heartbeat. So again, it doesn't throw stuff off, but there's just 1 or 2 little brats in the background doing weird stuff. So it doesn't upset the whole system. You're still basically in control. Things are going on. But if the whole class is in chaos and everybody is misbehaving and doing weird stuff, that's kind of like being in VFib. And so obviously it's a bad situation, and you have to do something dramatic to fix it out. Which in Eric's example, what he did next was slap the table, and which I don't know if teachers are allowed to do that ever. But basically you do something abrupt to shock people out of this extra noise that's going on, which is what being defibrillated is all about. Okay, it's just putting a lot of voltage into not a lot, but a fair amount of voltage into the heart to snap it out of this bad stuff that it's doing. Okay, so that's what the AED is about. That's what defibrillators are about. And that's what now any more people that have established that they have these underlying propensities to have too many extra heartbeats, they end up with intrinsic devices or defibrillators or machines that will shock them out of bad rhythms if it picks it up. So there's a lot of those in our room, and they're in there for various reasons. And some people just have pacemakers, and some people have defibrillators, and some people have defibrillators because they have a history of having bad stuff happen. They had VTAC, and some people have defibrillators just because they're at risk, because they have heart failure and they're more likely to do that whether they've ever done it or not. So those are all common scenarios, and I'm pretty sure Dr. Luca Putnam will kind of talk about that when she comes. Did you have a question, Kevin?
Yeah, if you have bypass or stent, does your rhythm change, was that EKG change somewhat? Or each side or lower?
Not necessarily, no.
If you had a bunch, you say you have 5 bypass.
No, I don't think it's the bypass that's gonna affect it. It's if you have scar tissue, if you had heart attacks before you had a bypass, yes, your EKG is probably gonna be different. But the bypass itself is not probably gonna change it. So this is a kind of a fun example of the tracing of somebody that has one of these devices. So here's his EKG, and he went into VTAC. Here's the VTAC, and the machine registered it for a while, and all this stuff means to them, So basically what the machine does, if you have one of these devices, is it picks it up, it's aware that's going on because of these numbers, and then basically it does a couple of things. One of them, it tries to, quote, pace you out of it. So it kind of tries to slow you down and sends out signals to try to make the heart rhythm slowly get back down to a normal rhythm. And if that works, that's great. You pace yourself out of it. And if that didn't work, then the machine actually does deliver a shock, not a very high one, but a big one. And then it sort of snaps you out of it and you go back into sinus rhythm. So that's what a defibrillator is doing its job. And do you mind sharing, John? I know you have one. Has it ever fired?
No, but I've gotten close up there.
Yeah.
Let's see, what were you doing Tuesday at 5:30 in the morning? Well, I was drinking coffee and then, well, you had 6 beats. If it had gone to 10, you would have noticed it.
Yeah,
There's no fire.
right. Yeah, they're very sophisticated. My rowing coach is a man who actually had a heart transplant a year or two ago. But prior to that, and he's a man who ended up with heart failure, and he's young, he's only in his 50s, but he ended up with heart failure because he had a rattlesnake bite induced cardiomyopathy. It was very bizarre. But he had a device, and he obviously could have learned a few things about clean living because he didn't really take very good care of himself with respect to some of his habits. He drank a lot and he probably partied a lot, etc. So, but he had a device and it was firing all the time. And obviously you don't feel so good if every other minute this machine is zapping you. And so he went in and had a gazillion ablations at UCSF, I think, over a 2 or 3 year time period. And then he ultimately fixed it by having a transplant. So I think that was his cure to fix his underlying heart rhythm issues. But we were always a little trepidatious to be out on the water with him as our coach, because was his box going to go off, and we had to worry about him needing to lay down for a while or not. And anyway, it's very individualized. Everybody has a different picture and reason for what's going on. And that's all I had. So thanks. Any other questions?
Yes, you did. Thank you very much.
This?
All right. Thank you.
Yeah, so hopefully that will help. And so when Dr. Buka is here and actually talks about devices, you'll have a better understanding why you might need one. And
Tomorrow?
no, it won't be for 2 weeks.
Thank you, Linda.
Thank you. We need to stop.
Thank you.
I think I'm ready.